you take the RVOT measurement in the short axis and you measure the annulus of the pulmonary, the hinge point to hinge point.
Yes, sir.
I have purposely avoided doing this here because this is a basic beginner's course. I did not want to confuse you with the pulmonary artery. Okay.
Sir, another thing, sir.
Yes.
So sometimes in mitral stenosis or mitral regurgitation, surgeon want to know about annular diameter. So how in which view we should give the annular diameter of the valve?
The mitral annular diameter is apical 4-chamber view.
So only one.
Yeah.
So we should measure in one view in two.
You must take repeated measurements. Remember that the mitral annulus is not a circular structure, so it is better to give in 4-chamber and 2-chamber view so that he may have a better idea. The other important thing is that if you want to measure the aortic annulus, then I've just shown you from trailing edge to leading edge. The picture that I was showing, that was the aortic annulus.
Okay, sir. Thank you, sir.
Thank you. Thank you.
Dr. Hiru, mitral annulus should be both in 4-chamber as well as 2-chamber with the mitral valve opened up, like mid-diastole.
Yeah, sir. Thank you, sir.
Okay. Dr. Sirisha.
No doubts, sir.
No doubts. All clear?
Little confused, sir. I'll go through the PPT once again.
Okay. Dr. Ganesh Tukaram Thomare.
No question.
Dr. Sayali Nandkumar Bhangre.
No question, sir. Thank you.
Dr. Sumant Kumar.
No questions, sir.
Dr. Ishwar Agarwal.
No question, sir.
Dr. Anupa George.
No question, sir.
Dr. Amit Kumar Dandhari Potulwar.
No question, sir.
Dr. Umesh G. Razur.
No question, sir.
Dr. Safaila Vishal Sardesai.
No question, sir.
Dr. Mitul Jain.
No question, sir.
Dr. Namdev Limbaji Chaure.
So no question.
Dr. Suman Chatterjee.
No question, sir.
Dr. Anchala Singh.
Yes, sir.
Any question, Anchala?
Hello. No, sir.
Okay. Dr. Rahul Gore.
Sir, yes, sir. Sir, can you just elaborate again the measurements in M modes, left ventricle?
Yeah, I'll show you. See, this is the peak of the R wave, that is end diastole, from leading edge to leading edge, septum. Again, from leading edge to leading edge, LV. Again, from leading edge to leading edge, LV posterior wall. Again, this is the lowermost part of the interventricular septum. Leading edge to leading edge, that is the systolic dimension. This is the diastolic dimension. This is the systolic dimension. Doctor, am I clear to you, or you want me to repeat it?
Sir, we should not take the dimensions end to end, sir, in cavity. For left ventricle systole, left ventricle end systole and diastole diameter, sir, one second.
End systole is from the lowermost part of the septum to the corresponding part of the LV posterior wall, from here to here. End diastole is at the level of the peak of the R wave from the leading edge to leading edge cavity.
Okay, sir. Okay, thank you, sir.
Thank you.
Dr. Shashank Prabhu Desai.
Good evening, sir.
Good evening.
I just want to ask in M mode for LV dimensions, sometimes how do you avoid the measuring, I mean, from the LV IDD at the end towards the posterior wall? Sometimes we get the papillary muscle or, trabeculations. So do we include that in the measurement or exclude it?
Now remember, my friend, when you are taking a 2D picture of the parasternal long axis view, there should not be a big fat inferior papillary muscle. If you see the papillary muscle, then your view is wrong. You change it so that the papillary muscle disappears. Am I clear to you?
Yes, sir. So, and one more in the for modified Simpson's method.
Yeah.
Again, during the tracing, do we include when you're tracing? I'm a little confused about you include those trabeculations or exclude them?
Remember that the trabeculations and the papillary muscles, they are part of the blood and not of the wall.
Okay.
The trabeculations and papillary muscle, consider them to be part of the blood-filled cavity.
Okay.
You
All
never
right,
make
sir.
a mistake then.
All right, sir. Thank you.
And remember that the mitral valve is also part of the blood. So you join the two mitral annuli by a straight line and not a curved line along the mitral valve leaflets. Okay.
Okay. Okay, sir. Yeah. Thank you.
Shashank, one more point is, if in your M mode LV cavity, if you are
Yes.
your papillary muscle, then you are not cutting across basal segments, then you are cutting across mid segments. So
Okay.
your view is wrong. Your
All right.
section should be just distal to the tip of the leaflets.
Okay, sir.
Anterior, basal, posterior wall.
Got it.
Okay.
Yes, sir. Thank you.
Thank you, dear. Dr. Jai Singh.
Sir.
Any question, Jai Singh?
Yes, sir. I have one question.
Go ahead.
Sir, which part of LV segment is supplied by proximal LED, mid LED, and distal LED?
Okay. Let me get back to those pictures. This is LED, this red artery. Am I right?
Yes,
so
sir.
The basal part is supplied by the proximal LED. The mid part is supplied by the mid LED. The distal part of the LED, the LV is supplied by the distal LED. Am I clear? Is that what you asked, or have I misunderstood you?
Actually, which segments in 17 segment?
No. Now I understand. Just hold on. There's a phone. I'll get back to you in 5 seconds.
Right, sir.
Remember a very basic concept, Jai Singh.
Yes, sir.
You have to differentiate whether it is basal, whether it's proximal LED leader, mid.
Sorry.
Please join, Abhijit. We are waiting for you. Please go ahead.
This is the short axis of the LV at the level of the base, at the mid cavity, and at the apex. You wanted to know which artery is supplying which. So get to this picture. See, this is the gray artery LED. Gray area is this and this. Anterior, anteroseptal. Anterior, anteroseptal. Anterior, here is no anteroseptal. Anterior and septal. All right. Now, this pink artery is a circumflex. It supplies the two lateral, inferolateral and anterolateral. This blue artery is the RCA. It supplies the inferior and inferoseptal. Am I clear to this? Clear to everyone?
May I add?
These two segments and LED. These two segments circumflex. These two segments PTA. Again, LED, circumflex, PTA. Again, LED, circumflex, PTA. Sir, you wanted to say anything?
Yeah, may I add one thing to it? He's asking, like, how can you differentiate proximal LED lesion, mid LED lesion, and basal distal LED lesion?
Okay, okay. See, if there is a distal LED lesion, only the apex is affected.
Correct.
See, this apex, these parts won't be affected. So this will be normal, this will be normal. Only this is showing akinesia. Again, if the mid LED is affected, then only the mid and apex will be affected. And if the proximal LED is affected, then base, mid, and apex are all affected. Am I clear to you?
Jesse,
Hello.
Dr. Abhijit has said very categorical one important thing.
Yes, sir. This time very clear, sir.
Yeah.
Yes, sir. Thank you, sir.
If you happen to see basal anterior septum which is involved,
Okay.
always think of a proximal LED lesion.
Right, sir.
If you see sparing of the basal anterior septum, you see a mid anterior septum which is involved, think of a mid segment lesion or mid LED lesion.
Okay, sir.
Right?
Right, sir.
Two parts are spared. Can you think possibly we are dealing with distal LED lesion?
Right, sir.
Okay. And why is important? Your question is very valid. Why it's important? If I see basal anterior septum which is not contracting, despite patient is settled, like hemodynamic is stable, but he's likely to deteriorate very fast.
Right, sir. Right,
sir. These people, they need quick interventions, you know.
Okay. Sir, is just like LED, is there any demarcation for RCA, proximal RCA, mid RCA, or distal RCA?
A very good question, Abhijit. You will take this question?
Yes, I'll take this question. You know, this question cannot be answered in 1 or 2 words because it all depends on whether the posterior descending artery is arising from the RCA or a left circumflex. Sometimes when the left circumflex is very big, then the RCA is very small. If there is an RCA obstruction, there is a small right ventricular infarct. On the other hand, if this is a large RCA and if there is a proximal RCA involvement, then you find the whole lateral wall and inferior wall of the RV has infarcted and become akinetic. Am I clear to you now?
Yes, sir. Or in general, people, sir, if right dominance is present, then at that condition, how will we demark, sir?
The absolute answer will come from coronary angiogram, but you will have to see the free wall of the RV and see how it is moving. If the whole free wall is moving very badly, then you must think that this is a proximal right coronary artery lesion. See, if it is an obstruction here, and this is a very big RCA, then the whole right ventricular free wall is involved. And you find that the free wall is dilated and not contracting well. Am I clear to you?
Yes, sir.
Dr. Jaising, Dr. Abhijit has very categorically said,
yes, sir. Yes.
Proximal RC involvement means looking at RV free wall.
Right, sir.
You have an inferior wall MI and you have RV free wall is hypocontractile. And then you can have dominance or non-dominance based on associated lesions. Like if it's only a non-dominant RCA, then you can see only proximal RCA or right inferior septum or basal inferior septum or basal inferior wall along with RCA which is involved or right RV free wall. If it's a dominant RCA consisting of PDA also, then you will not find only the RV free wall which is hypokinetic. It will be associated with circumflex territory also.
Okay, sir. Right.
Okay, let's move on to Dr. Shrikant Rajvilas Gote.
No questions, sir.
Vinay Sharma.
No questions, sir.
Anudeep Reddy.
Sir, no questions, sir.
Dr. Karnveer. Dr.
No questions, sir.
Okay. Dr. Samrat Sukumar.
Good evening, sir. Very nice presentation, sir. Very concise presentation. Sir, I had a couple of questions. My first question is, sir, in myocardial performance index, do we always need to use tissue Doppler imaging? Can it also be properly validated with the use of continuous wave Doppler? My another question, sir, is in the measurement of the aortic valve annulus, especially in very stenotic or very heavily calcified aortic walls, sometimes we underestimate the valve area. So are there any tips or tricks in this heavily calcified wall to measure the aortic annulus?
I'll take your question. There's a phone call. Give me 5 seconds. I'll get back to you.
Yes, sir. Yes, sir.
By the time Dr. Abhijit is taking his phone call, first of all, we never use aortic valve area for planimetry.
Sorry.
Yes, sir.
There's a new admission in the hospital. There are phone calls. Yeah. What was your question, please? Can you repeat it?
Yes, sir.
Myocardial performance index. And he said myocardial performance index, can we take from tissue Doppler only, or we have some other method of doing MPI?
You can do it by conventional Doppler, like pulse wave Doppler. You can also do it by tissue Doppler. The normal values are slightly different from one another.
Can you show the method? If you
Yes.
Yes, I'll show you the method. This is the mitral valve flow. Again, next cycle, this is the mitral valve flow. And this is the aortic valve flow. The mitral valve flow ends, and there's a small gap, and the aortic flow starts. So during this small gap, the ventricle is contracting well, but both the valves are closed. So this is isovolumic. The volume does not change, but the pressure rises. And when the pressure rises, the aortic valve opens and ejects blood. Again, when the aortic valve has stopped ejecting blood, the aortic valve has closed, but the mitral valve has not yet opened. So this is a part of the cardiac cycle when the myocardium is relaxing, but both the valves are closed. This is known as isovolumic relaxation time. Myocardial performance index is isovolumic contraction time plus isovolumic relaxation time divided by ejection time. See the top here, they have given the formula. Isovolumic contraction time plus isovolumic relaxation time divided by ejection time. Am I clear to you now?
Yes, sir. Yes, sir.
You can do it by the other method also. See here, the ejection time is defined by the beginning and end of the systolic wave. And before that, isovolumic contraction time and isovolumic relaxation time. So isovolumic contraction time plus isovolumic relaxation time divided by ejection time. Am I clear to you
Yes.
now?
Yes, sir. Yes, sir. Yes, sir.
But
so my second question.
Yeah,
second
we'll
question
come to
was,
the
sir,
second question is, but in practice, we do not measure IVCT, IVRT. What we do is we look, can we go back to previous slide, Dr. Abhijit?
Yes, sir.
What we measure is we measure mitral closing and opening time. That will consist of IVCT, ejection, IVRT. So that is interval A.
Yeah.
A minus B.
Yeah.
B is the ejection time.
Yeah. A minus
yes,
B.
sir.
A minus B divided by B will give you myocardial performance.
Yes, sir. Yes, sir. Yes, sir. Yes, sir.
That's a
Yes, sir.
practical
Clear.
way,
Yes.
because we do not measure IVCT and IVRT.
Right, sir. Yes, sir.
Second question is like measuring aortic valve area by planimetry. What is saying? He says we underestimate aortic valve area by planimetry.
Now, doctor, I'll answer your question. Whenever in adult cardiology, you want to measure the aortic valve area, never try to do planimetry. You'll go haywire. You'll be absolutely wrong. The measurement should always be taken by Doppler, continuity equation, and peak and mean gradient. Am I clear to you? We will
Yes,
teach
sir.
you,
Yes, sir.
when we teach aortic valve stenosis, we'll tell you how to do that. Because, you know, most of the adult aortic valve cases are heavily calcified, and then you can't know which is the edge and which is the tissue. So, and there's a lot of shadowing because of the calcium. The results are all wrong. You have to take
Right,
the
sir.
Doppler
Yes.
measurement.
Yes, yes, sir. Yes, sir. Yes, and one more question, sir. So I had one more question, sir. Sir, while measuring the IVC diameter and especially the compressibility, do we do in the same way in a mechanically ventilated patient, sir? Because usually IVC distance during inspiration in those patients. So do we have to apply the Valsalva maneuver on the ventilator, or is it done in the same way, sir?
Wherever you find the discussion of the IVC measurement in any textbook or journal, they always say that these measurements and these statements do not apply to ventilated patients.
Yes, sir. Okay.
Here, your measurements can be absolutely wrong.
In those patients, Samrat, what exactly do we do
Yes,
is
sir.
we take E to E prime ratio.
Okay. Yes, sir.
Tricuspid flow E prime of RV free wall TDI.
Okay. Yes, sir.
Less than 6 versus more than 6. If it's less than
Okay. Okay.
or more than 6, based on that, we say whether RA pressure is elevated or normal.
Okay, sir. Yes, sir. Thank you, sir.
Amogna Das.
Sir, good evening. Sir, can you
Good
please repeat the LA measurements? How to take the LA measurements?
Oh, yes, I'll do that. Yeah, I was saying that the LA is a three-dimensional structure. So you cannot take one-dimensional measurement and say that this is representative of the entire three-dimensional structure. So you'll have to take measurements from two orthogonal views. That is the four-chamber view and the two-chamber view. They are taken in end systole when the LA dimensions are at their largest. Tracing should start from one annulus, go along the inner margins of the interatrial septum and LA wall and end at the other end. You should be careful not to trace inside the pulmonary veins or the LA appendage. The two annuli are joined by a straight line. The midpoint of this line is joined to the most distal point of the LA wall. This is the long axis measurement. See what we have done. End systole. Mitral valve is tightly closed. Start at one annulus. Trace along the inner surface of the septum. Don't go into the pulmonary vein. Go along the inner surface of the left atrial wall. End at the other annulus. Join the two annuli by a straight line. Start from the midpoint of this line and go to the distal most point and enter. The machine will cut it into 20 slices as if you are slicing a loaf of bread. You do it in 4-chamber. This is 4-chamber. Again in 2-chamber. And the machine will give the LA volume. Am I clear to you, Dr. Das?
Yes, sir.
All right. Let's move on to Dr. Durgesh Makwana.
No question, sir.
Dr. Kevin Bora.
Sir, can you please tell me how do we suspect pulmonary embolism and how to take PA pressures?
Pulmonary embolism, only rarely in your career will you find a pulmonary embolus passing across the right side of the heart, right-sided chambers. It is usually diagnosed by means of enlargement of the right ventricle and right atrium and maybe the inferior vena cava. And there is something known as the McConnell sign where the RV is hypokinetic with apical sparing. So we will discuss that when we discuss about the pulmonary hypertension. That is a different lecture.
Okay.
We can share a couple of salient point there. We can share a couple of salient points. How do we differentiate? How do we suspect pulmonary embolism?
Sir, we find the RA, RV and the IVC dilated. The tricuspid regurgitation velocity will be high, thereby indicating pulmonary hypertension. If you are lucky enough, you can see an embolus in transit, and in spite of the hypokinesis of the RV, the apex of the RV will not be hypokinetic. This is known as the McConnell sign, that is the apical sparing. Am I clear to you?
Yes, sir. Sir, can you tell me how do you take PA pressures?
The PA pressures are not
Kevin,
part of this lecture,
Kevin, I'll
but
show you PA pressure next time.
Okay, sir.
Dr.
Right.
Parasha
Thank
showed you, but I'll show you PA pressure next time.
I've got a slide here, but if
Do you have a
click it,
slide, Abhijit?
I think
No.
I can find it out. Yeah.
Okay. So that will open a complete box. Abhijit, let's hold on. I'll show them next week.
Okay, sir. Okay.
Dr. Ravi, are you there?
Yes, sir. No questions, sir. Thank you.
Dr. Chandan Kumar Roy Mahapatra.
No, sir. No questions, sir. Thank you, sir.
Yogesh Namdev Patil.
Sir, good evening.
Good evening, Yogesh.
Sir, I just wanted to ask a few queries. I mean, regarding, sir, RV OT measurements, I mean, told in proximal, distal, and middle, RVOT measurements at proximal, RVOT, middle, and distal. How to do that thing? I mean, that was shown, but I just missed that because I was on a call. Just wanted to see that thing, sir. And secondly, I want to know about RA measurements also, sir.
Okay, I'll do that. If you want to take measurements of the right side of chambers, look at the lower panel. This is the standard apical 4-chamber view.
Okay, sir.
And if you angulate the transducer towards the sternum, you get a RV focus view. This is the RV focus view.
Okay, sir.
And once you have got the RV focus view, now see what I'm doing.
Abhijit, can we enlarge your slides if possible?
Yes, sir, I'll do that.
Thank you. Thank you very much.
See, this is from one annulus to annulus. Do not take the measurements of the RV from annulus to annulus. Just above the annulus is a dilated portion of the RV. So, from inner edge to inner edge is the basal measurement. And from the midpoint to the apex is a long axis. And from this is the mid cavity measurement, inner edge to inner edge. This is the RVOT proximal. This is a short axis. This is the RVOT distal. And this is the annulus, that is the pulmonary artery annulus. This is a PA measurement. And this is a measurement of the RV free wall. You have to measure from subcostal view with the tricuspid valve leaflets fully open at the level of tips of the tricuspid valve leaflets. Be careful not to measure the epicardial fat or the endocardial trabeculation. See, there is a lot of epicardial fat here and endocardial trabeculation here. The normal value is less than 5 millimeters.
Also about RA measurements.
RA measurements.
Oh, yes, I'll show you RA. RA measurement, you have to start tracing from one annulus to the other annulus along the inner surface and joined by a straight line. From the midpoint of this line, if you draw it parallel to the interventricular septum, this is what is given in the AAC textbook. This line should be parallel to the septum. And perpendicular to this line, from inner edge to inner edge, the widest portion, there is a short axis. Short axis should be less than 44 millimeters. See here. And if you planimeter it, the normal value is less than 18 square centimeter, irrespective of the body surface area. Am I clear to you now?
Yes, sir. Yes, sir. Sir,
you can get all of this, whatever I have been discussing, from the American Society website, the guidelines. You can download it free of charge. You need not subscribe.
So one more thing. Everybody, every report we see of echocardiography, everybody measures D slope, EF slopes, APSS. Everybody mentions it, but nobody talks. Everybody just in whatever talks I have gone for, everybody just lets it go by historical importance. So I just wanted to know what is the historical importance.
Really, there is no necessity of measuring E amplitude and EF slope and EPSS. These are of historical importance only. You might as well omit that when you do your echocardiography in your hospital.
Okay, sir.
Yogesh, there was a time when we never had 2 dimensions echocardiography. So what was E-point septal separation? It was when E-point septal separation was more than 7 millimeter, we thought LV was dilated. That's how. Then we had mitral stenosis. When mitral stenosis were there, mitral valve opening was restricted. So D excursion was reduced, EF slope was prolonged.
Okay.
So those are the periods when we talked of echo in M mode during 70s.
Okay, sir. Okay.
So, but still, I don't say I do not say that it's historical. It still happens in India.
Yes, sir. Because every report has got it mentioned. That's
why it still happens in India. We do not say historical. So it still happens in India, and that's how they explains you.
Okay. Thank you, sir. Thank you very much.
Right. Dr. Majrul Islam. Dr. Islam,
Yes, sir.
question?
No questions, sir, at present.
No questions. Okay. Dr. Farheen Ayub Khan. Dr.
Yes, sir.
Good
Yes,
evening.
sir. Good evening, sir. I wanted to ask you how to calculate dP by dt.
dP by dt, Abhijit.
Yes.
dP by dt. Yeah, I'm sorry, I don't have a slide here. So you have to measure the difference between the velocities of the tricuspid regurgitation or mitral regurgitation from 1 meters per second to 3 meters per second. That gradient. I don't have a slide here, sir, because it was not part of the discussion.
Nida, I'll show you dP/dt. Next week, just make me remember, I'll show you dP/dt. Most commonly used for a mitral regurgitation. And I'll show you how to measure it. Okay? Any other question?
No, sir.
Dr. Sai Prasad?
No question, sir.
Dr. Manu Kapil?
Sir, no question.
Okay. Dr. Clay from Tanzania. Dr. Clay, are you there? Dr. Clay. All right. Dr. Clay is absent today. So I think we are done, Abhijit.
Okay, sir.
Very much for excellent deliberation and good questions, because the question only tells you whether they have understood something or not.
Thanks, sir.
With this, I would like to pay thanks to you and your final comments before we say goodbye, Shabba Khair, and see you next week.
Thank you. Bye-bye. Good night.
All right, friends, we'll see you next time at 5 o'clock in the evening for a live demonstration. So all of you get ready. We'll quickly show you all live demonstration next week.
Okay, sir.
Few words. Let me have a pleasure of thanking Abhijit again.
Thank you, sir.
Thank you all for patience hearing. And this time, I'm again thankful to you for not making any noise during this. Thank you.
Chubb is here.